Today is World Asthma Day, the 5th of May 2021. The celebrations are organized by Global Initiative for Asthma, which is a World Health Organization collaborative organization founded in 1993. It's held in each May to raise awareness of asthma worldwide. Although asthma cannot be cured and it's possible to manage asthma to reduce and prevent asthma attacks, also called episodes or exacerbations, this year's World Asthma Day is themed Uncovering Asthma Misconceptions. There are very many misconceptions. Among those that have been listed are: one, people say asthma is childhood disease and individuals will grow out of it as they age. Don't worry, as they grow older, it'll go. Misconception. Second, that asthma is infectious. Third, that asthma sufferers should not exercise. That because you have asthma, don't exercise. That it's only controllable with high dose steroids. The truth is, according to this a global alliance on asthma can occur at any age, in children, adolescents, adults, and even the elderly. You can get asthma. Asthma is not infectious, but with viral respiratory infections such as common cold and the flu, you can get asthma attacks. Or in children, asthma is frequently associated with allergy, but asthma which starts adulthood is less often allergic. When asthma is well controlled, the asthma subjects are able to exercise and can even perform top sport. Also, asthma is most often controllable with low dose inhaled steroids. You don't have to go into lots of steroids. But there are very many people that you speak to today and they tell you, I know somebody who has asthma, or they tell you I'm asthmatic. I walk around with my inhaler. What the issues that would then arise are: number one, do we actually have a way of getting information and keeping statistics on asthma in the country? Do we know how many people have asthma? Do we know the kind of support that they require? Do we know the kind of support that they get from the government or from communities, or is there such programming in place? Let's bring in an expert on these matters. Dr. Josephine Muiru is a medical advisor with GlaxoSmithKline Pharmaceuticals Kenya, that's GSK. Dr. Josephine, good morning.
Good morning, Eric. How are you doing?
Very well, thank you. Welcome to the Situation Room. Happy World Asthma Day.
Happy World Asthma Day to you too.
Now, you are a medical doctor.
Yes, I'm a medical doctor with the technical know-how, but I don't see patients in a regular day-to-day basis.
Okay.
So, as my title says, is generally medical advisor.
Okay.
Right? And today's, as you've well put it, today is uncovering asthma misconceptions. Right? So, this conversation that we're going to have, it's not, what the government is doing or what we are doing. It's focused mainly on the patients. Because the patients themselves or the general public are the ones who have a misconception of what asthma is. Right? So, for example, and I'm sure someone in the studio or even yourself, someone who has asthma. So what's the wildest thing that you've heard about asthma?
Difficulty in breathing. And someone gets an asthma attack, and if they don't have the inhaler next to them, then things go south pretty fast.
True. That does happen. But the misconception, what are the myths? Because this is uncovering the myths.
What myths?
The myths?
Yes.
Well, if something affects your breathing, you assume that it is lodged somewhere in your lungs.
Yes.
And,
okay.
And we know the function of the lungs. I thought we were taught in biology, I think, as earlier, I think, Form 1, and it has stuck. So I understand that. But the details of what else, whatever parts of our bodies that are also pertinent to the functions of breathing, if the lungs are affected, you assume those would also be affected. But then affected, what I don't understand is what affects them. What is it that causes this thing we're calling and what is it? Are there things that can exacerbate it? Are there things that can make it worse? And how does it even begin in the first place? Is it something that happens to you? Is it hereditary? Are you born, or are you just born with it? What is it?
Okay.
Another one of the myths that I've heard is that,
Yes.
and I think quite often, I have an asthmatic sister, but then so I knew it was not true. But one of the things that I've heard from a lot of people is that, asthma is caused by dust and cold, and that's the cause of asthma.
Cons are cold, man.
So, there are little bits of, the thing about myths, there are little bit of truths in it, right? But now it's just to get what is the actual truth, right? So let's talk about, people thinking there's something lodged in your lungs. So yes, asthma is a disease that affects the, respiratory system. And you are not taught wrong in biology. The lungs are also involved, and the airways, whatever takes the air to the lungs is what is affected mainly. Okay? So what usually happens is if this person is susceptible to asthma, or the triggers being, examples, the cold, the dust. So those are not the causes of asthma. Those are the triggers, right? So So if this person is exposed to whether it's the pollutants, whether it's any exhaust fumes, whether they are working in a farm that they're dealing with fertilizer, so that causes irritation to the airways. And when that happens, the airways inflame. They get swollen. Okay, so when they get swollen, and they can also have extra mucus, that's when when something gets swollen, if it's a tube, if it's a pipe, if you fill it up, if the walls start getting smaller, then definitely you'll be unable, there's restriction in the airflow, in the airways, right? So hence why you have the difficulty in breathing. So about the causes
So that's
of
a
asthma.
trigger.
Yeah.
Yes, now let's talk about the causes.
So the causes. The causes are not well known, unfortunately. However, they say it's a combination of ideally risk factors, one, and then it's probably combination of environmental, so what is out here, and also inherited, so the genetic factors. So could be a combination of the two. Hence why, your sister has asthma and you don't have asthma. But if you look carefully, there's someone somewhere who had some genetic factors.
So there'll be a history of asthma somewhere.
A history of asthma or history of allergy.
Okay.
How do you distinguish it? I mean, how do you tell that this person has an allergy and this person has asthma? How do you actually tell the difference? There are people who constantly seem to be blowing their noses and sniffling. So if someone is constantly sniffling,
they don't like cold environment.
Do we say that they have asthma? Somebody who's always complaining about dust or they're complaining about the cold?
So it's distinguishable, okay? So there are those with allergy, okay, just by itself. Okay, and there are several tests that we are able to do, or doctors are able to do, to distinguish or diagnose what exactly you're allergic to. Okay, then there are those patients with asthma. Okay, and allergic asthma. So the allergies or the allergens, the triggers, like the dust, the cold, can trigger an asthmatic attack. So it doesn't necessarily mean that a patient with allergy, has asthma. Okay. And even and then there's also non-allergic asthma. So this is asthma that is not related to any allergens whatsoever.
Okay. So can we say then that the person with asthma is the one whose airways are predisposed to becoming inflamed and narrow, hence constricting breathing? Yes.
So now, even for a patient with asthma, right? And a patient who suspects they have asthma, or even if you're a caregiver and your child, you suspect this child is having issues breathing, then it's seek healthcare, go to your doctor. They will be able to do the history taking, right? They'll be able to do the physical exam, okay? And probably also send this person for lung tests. Okay, there are some breathing tests that are available, okay? So when they do the lung test, is when now you can come up with a diagnosis, a firm diagnosis of asthma. Yes.
So
Okay.
what are these inhalers? What do inhalers do? What are they?
Okay, so there are different types of inhalers. Okay, but mainly the ones that are used for asthma. They are either the long-term control medications. Okay, and these ones help keep the swelling, the inflammation under control. So once that is under control, then that means the asthma attacks become less. So the exacerbations decrease. Okay, so you find that patients are told to continuously take the medication. One, because the asthma is a chronic disease. It's not something that comes on Monday and will disappear on Tuesday. No. It's a chronic disease. Just the way you'd look at hypertension, just the way you'd look at blood pressure disease, asthma is a chronic disease. So patients need to continuously take that medication. One of those is the long-term control medication. I'm sure that now that's when Eric had mentioned the steroids, right? So that's part of it, okay, to control the inflammation. Then we have the relievers, okay, and their work at this point is just sort of rescue medication. Okay, so when this person is having an asthmatic attack, they usually grab their rescue medication, so that they can quickly, so the airways can quickly relax, and then the air is able to go through, and hence stop or sort of decrease the severity of the asthma attack.
Again, on this matter of this matter of inhalers, you said that is the one thing they do. But is it just that, or do you have inhalers that also perhaps perform other functions?
No, ideally that's what they do.
So irrespective of whatever name they are given, that is primarily what they all do.
Exactly. And it's dependent on, it comes in very many devices, dependent on manufacturers, one of them. But mainly, it's either they are long-acting, they are there for long-term control, or they are the relievers, one of the two.
And is it the same for children as well as for adults?
Yes, definitely. It is.
Same dosage.
So for the children as well. So no, it's not the same dosage. Okay, that's the other thing. So the goal of treatment for any patient is to get them to have their asthma under control, and under the minimum effective dose. So the first misconception that you're saying that people assume that you have to be continuously on high dose therapy. No, patients' treatment is very individualized. So whatever will control Eric is not what will control Josephine, is not what will control Peter, it's not what will control anyone else, right? So it's very individualized. So the doctor, these conversations need to continue. They need to keep on assessing the asthma control in this patient, in patient A, and get it to a level. If it's under control under X dose, then keep it to that minimum X dose. Then keep on reviewing and assessing this patient. But the patient, again, will continuously be on treatment.
If someone can't afford inhalers, what are the options? What other options are there? Do you have tablets? Do you have syrups?
Or some concoction.
Or some injection of some sort. I mean,
you can just do sugar, lemon, honey, whatever.
What exists and what else can one do?
Eric, you sound like those people who used to go to hospital and say you won't leave the hospital until you're injected.
Yes, the Eric who spoke of the injection is actually called C.T. Muga. It's an older version of this other Eric. Yes.
Sorry, Muga, how are you?
No, we like appearing in two forms. The only thing that will ensure that when the same person is, we all wear glasses. So, and when you smile, you can see our teeth.
So there are different medications. However, what is advocated for in the treatment guidelines, okay, is actually inhalers, because you find that all these others, whether it's oral tablets, okay, means that you'll have to take oral steroids. Okay, those are not going to be safe. They have several other side effects. Okay, so why not have an inhaler, right, which is going to act faster? Because you can imagine patient A has an inhaler, patient B has the oral steroid. Now, they both get an attack. So they are, on asthma control, right? So this patient who swallows this medication, patient B, versus patient A who takes the inhaler medication, right? They will most likely have, the one who takes the patient B, for it to act may take about 30 minutes, right? Patient A, 5 minutes, and they are good to go. They are fine.
All right. So what about alternative methods of treatment? Like, because I'm walking into my sister's house and there's a diffuser on with eucalyptus oil and basil. I don't know what smells like an apothecary all the time, but it seems that there are now alternative treatments that have been introduced, especially as the world goes towards this herbal, kind of, do those work? Because she would say that, I feel things are looser. I feel relief in my chest. And then I wouldn't have to use my inhaler as much. Does that work, or is it advocated for?
So now, let's just take a perfect example. If you have a flu, okay, and you're feeling blocked up, and you steam, and put your menthol and whatnot, inside there, do you feel better?
You feel better, yes. Yeah.
Yes, you do feel better.
Yeah.
But that doesn't take away the fact that you'll have to still take your other medication. It relieves the blockage, it helps you. But for your sister, she shouldn't stop her inhaler medication. She'll find that probably, she'll not use her reliever medication as often as, But it doesn't take away the fact that she has to still be on her long-term medication. She'll probably be on a lower dose, but she should be on her medication consistently. And that's the issue. That's the other misconception that we have found, that patients assume that once they have had their wheeze or their cough, and they take their inhaler, that disappears. That means the disease has disappeared. That's not the case.
That's not the case.
Can
you move along levels of asthma? Because we see that, there's severe persistence, then there's mild asthma, there's moderate asthma.
Yeah.
Can you move along the levels as you progress?
Now, take this patient A who doesn't use their medication as regularly as, okay? So you could have started off as mild asthma, and then the next, and you have an exacerbation. By the time the doctor is seeing you, you could have moved up levels to probably a moderate asthma, okay? So the ideal is you continuously take your medication at whatever level you are, whether you first showed up to the hospital with, moderate asthma, okay? You take your medication, it's under control, okay? Your quality of life should remain as normal as anyone else who does not have asthma. Okay? So the underlying statement is adherence and, compliance to their medication.
To the medication. Okay. So asthma patients who got sick with COVID must have had a hell of a time because breathing normally was a problem. And then now those who would have gotten COVID, it would have been terrible. So, just looking at world statistics, looking at things that would we see that those who were asthmatic and then got COVID and then recovered, would the situation have been, would their condition have been worse after having survived COVID with asthma?
Okay, not that I'm an expert in the COVID area.
Sure, but
yes, I had to state that first. But what was seen in the different studies, patients with asthma did not increase their risk of getting COVID.
Okay.
So we all know at this point, anyone can get COVID. Okay. It also did not predict whether they are going to get the severer form or, the milder form again, right? But we know that COVID affects the lungs. Okay. So you already have this person who has issues with the lungs. Okay. Then they go through the COVID phase and unfortunately get out of it. So even patients who were, or people who did not have asthma, getting COVID, their lung capacity, or there is something that, they are deteriorate. So even with this patient with asthma, there is something that would change. Okay? And their asthma control, probably they are getting more exacerbations or flare-ups or attacks after the COVID, but it still has to be, assessed, reviewed, and their medication stepped up to a point where it's now they get back to where they were with asthma control.
Dr. Let me ask this question. What happens when the inhaler doesn't work?
What do you mean? That's a good thing, because now that's the other thing that patients come with. Daktari, my inhaler doesn't work. Hii dawa haifanyi kazi. Okay?
But it doesn't work. What do you mean? You
It
press
fails at that
Yes,
moment,
but-
or you use it over time. It's
doesn't
not
give you the
functional.
relief.
If you use it, you don't have relief.
Okay.
You can sort of
So-
depress it and breathe in as often as you like, but no relief. What do you do?
So the question the doctor should ask, okay, where did you bring the inhaler? Yes, no. How are you using this inhaler? Okay.
Let's
Because
say all that has been
the-
checked and you're doing exactly
Yes.
what you're supposed to do. And
Yeah.
it's there, and yet it's not
full.
doing what it's supposed to do.
So then at that point, when you have been assessed, you review the medication. So this person may need to have a higher dose of this medication. Okay, so you're stepped up. It's
At
called
what
stepped
point
up
do
therapy.
doctors then prescribe steroids?
Well, the inhalers have steroids.
Yes, but clearly
Yes.
sometimes the steroids within the inhalers don't work. So perhaps an injection might work. I'm bringing the discussion of the injection. The injection now comes in.
I know you're going back to the
Mimi nataka
injection.
shindano.
Muga, clearly you're a difficult one. Daktari sitoki hapa. Bila injection.
Bila shindano, how do I know I've been treated? Hii tembe haifanyi kazi.
So,
Kwanza hii hewa ambayo napuliza pia hii haifanyi, sasa shindano.
so you're the patient who will most likely be highly assessed, right? How you're using that inhaler, others continue using it when, it's empty, there's no drug in it per se, right? But the idea is, and the cycle is with asthma, you review, you assess, you adjust, okay? And that's a continuous cycle, whether you're doing well, so every time that you're going to see the doctor, okay? And when the doctor sees that, yes, indeed, that you've been using your medication well, your inhaler technique, has been good, is good, and all those parameters are checked, yes, then they adjust your medication, okay? So in asthma, it's either if you're not under control with X dosage, then you are stepped up to Y dosage. Okay. So when you get the Y dosage, you will have to be reassessed, okay, sooner, okay, to see whether your asthma symptoms are under control.
Okay.
Okay. So the doctor will keep on stepping up, assessing, okay, and adjusting when need be.
Okay.
When need be. The inhalers do work, the steroids do work, because as I mentioned at the beginning, these ones control the swelling, the inflammation. That's why, it's advocated for in the guidelines.
Daktari, a couple of questions that I have. I'll ask two. One, do you outgrow asthma? And number two, is it seasonal? Like, are there bad seasons, good seasons? When it's hot, you're okay. When there's pollen, you are a high risk. When it's really cold in July, then Kenyans who have asthma are then also having a difficult time.
Okay. So the first one, outgrowing symptoms. You cannot outgrow asthma. Okay, so the asthma symptoms, and this is going to probably also touch on the second question, right? Asthma symptoms are variable from time to time. Okay, depending on what your trigger is. So of course, if it's cold, July, June are hell for you. Okay, if you're one person who when it's flowering, when there's a lot of pollen in the air, of course the exacerbations, you're the one who'd be more prone to attacks. Okay, ideally, as I mentioned previously in the first session, asthma is a chronic condition. Okay, meaning that you'll continuously have to take your medication, so that when this June, July comes about, it's not as bad as someone who has not, is not taking their medication. Okay, so I think the misconception about outgrowing asthma comes about when you're dealing with children. Okay, because with children, one thing that is also very difficult about them is how the asthma is diagnosed. Okay. So it's already difficult to diagnose this child with asthma, because you're not going to expect them to go through the diagnostic test. There are some who are as young as 3 years old. They are unable to do the lung test. Okay. And then there are those amongst them, and this is the group that is hit severally by this respiratory, they're down with the flus constantly. So even those ones, the infections can sort of make them wheeze, okay, because the airways still get inflamed. But is that asthma? Sometimes not, okay? So you find that probably this child had the diagnosis of, transient wheezing, meaning that they were wheezers, but then it goes once their body, normalizes, accepts the environment and that sort of thing. Okay? Yeah? So that's probably where the misconception came about, because you'll hear, my child used to, or I used to wheeze when I was a child. Yes, exactly. Now I don't. So probably that's where the misconception came about.
So then how do you explain situations where someone has asthma as a child, and then when they grow older, they no longer seem to have those complications?
And they've been diagnosed with asthma.
Yes, they were diagnosed with asthma as a child, and when they grow up, when they're adults, they don't seem to have the same problems.
So there's that subset of children, okay? So where they kept on getting infections. These infections are triggers to asthmatic attack, okay? So you're on your medication, right? Or they're consistently, whatever allergy it is. So there's a subset, 0 to 10 years, and somewhere just before teenagehood, okay? These are the ones who most likely, outgrow asthma once their body gets desensitized towards the allergens. So those are the ones who outgrow, quote unquote, the asthma. Yeah. But if you get it, closer to adult onset, teenage years and above, okay, you are most likely not to outgrow your asthma. So that's why that's where the misconception came about.
So if I understand you correctly, Daktari, what you are saying is that if you manage this condition well over time, then you can get to a point, and you know exactly what the triggers are and you avoid these. Then you can get to a point where you no longer have a problem with asthma as is traditionally assumed. So you can live what one may refer to as a normal life.
Yes.
Without the need for constant medication.
No. So one of the ways to avoid the to control your asthma is identifying, okay, and knowing your triggers, okay. So if your trigger is environmental, how easy is it for someone to avoid going outside? Muga.
How easy is it?
It's not easy.
It's not easy.
It's not.
Definitely it's not easy. So you cannot say total avoidance unless you're going to wear a bubble around yourself. Okay? So these triggers will be there. Okay? So you need to, but
you
know
basically can
that-
manage them. So, for example, you
But
know
you can
that you're
manage.
cold, and so you make sure that you're not cold, you're regularly
You're
warm.
not exposing, you're not exposing yourself to those. If you're working in a factory where you're constantly in chemicals, because there are some who get irritated by those fumes, okay? Find a way to, to not, or get another job where you're not in contact with this.
Yeah.
That is keeping on irritating you. However, it still doesn't take away the underlying issue that asthma is a chronic disease.
Are we looking? I mean, as diseases and conditions like this have been studied over time, then you get to understand how they have been, and how they affect people. Now, if you're looking at the last 10 years and then today, where we're commemorating this particular day, have we seen that the disease, or rather the condition on its own, as a condition, has it gotten better? Is it more prevalent amongst people? Are we seeing younger people getting it? Are we seeing more people getting it? Are we seeing that more and more people are predisposed to it? What's been the evolution of asthma over the last few years?
So it's a good question that you've asked, and also touches on what Latif had mentioned at the beginning. How do we know how many people at a certain time are suffering from asthma? Okay, so we need things like asthma registry, where we'll be able in every hospital. So any patient who comes in is diagnosed with asthma, is put down in the registrar, and we are able to follow up and get this evolution. Unfortunately, and I'm saying about the developing countries, the lower middle income countries, information and such information is not readily available. Okay, in the developed countries, it's very easy for them to tell this year X is the it's 5% prevalent okay of asthma. But when you think about it, where we are now and where we were 10 years ago, there are more cars on the road. So the exhaust fumes, the industries are up and working, right? People are more obese because obesity is actually a risk factor, okay? So when you're eating not healthy foods, you're more prone to get, to become obese, and hence, you're making yourself more susceptible to actually developing asthma. So definitely things that were there 10 years ago, or even, when the industries were beginning, let's just say, when the coal industries, when there was a pet stores, all that, of course, the asthma prevalence was much more, but they did not have the medication, okay, at that point. But now, where we are today, the risk factors may be changing, okay, the face may be changing, but it doesn't take away the fact that, yes, there are people who will definitely get asthma due to the environment, again, one. And also remember the other thing was inherited, genetic as well. But we need to have the asthma registries up and going so that we can be able to, the government, help these patients and be able to follow them up and see, where they're going, where we were, and where we are heading to. Because you might find that, it might get worse. I'm just saying worse.
Yeah.
Or even better. Yeah.
Doctor, if somebody gets an asthma attack near you, and you search their pocket, their handbags, you don't see an inhaler, what should you do?
Now that's the other thing.
First of all, how do you identify that what they're actually suffering
Yes.
is an asthma attack?
Exactly. Because it looks like someone who has choked or someone who has just gotten, cannot breathe generally.
Yeah.
Because it generally cannot breathe. Okay? And probably, I think it was as recent as probably last year, I think my friend also got into that situation. Okay. The best thing is that they are healthcare professionals.
Okay.
So this person fell on the street, had just left hospital and had the hospital card. That was the benefit
grace.
or the advantage at that point. That was a saving grace. Other than that, if someone fell on the road and starts having issues breathing, especially in this setup for pandemic, the first thing people will do is flee.
Yep.
And just watch and wait. And that watching and waiting, this person will most likely die, right? So it's a very tricky situation, dicey situation, seeing that we don't have emergency protocols. Very few people actually know first aid. So someone collapsing in front of a healthcare professional, even I, as a doctor, the first thing I would probably do, as a human, would be like,
take off.
Wait. Take off first, and then you're like, oh, wait. I think I may be able to help this person. Yeah.
So what should you do?
So what should you do?
So if they have, because most people, and that's why they are actually told, walk around with your reliever.
Okay.
For that quick action. So patients need to be walking around. If you're asthmatic, leave alone the long-term control, the reliever medication that
But Dr.
comes in handy, yes.
So I don't have asthma. I am with Eric, and he has breathing problems. I don't know what is going on, but at that point, his breathing is restricted. What do I do at that point?
Check. It's usually the ABCs. Check the airway. Maybe he choked on something. He choked on the gum he was chewing. If you're able to clear off the airway, then you remove the gum. That's easy, because that way he'll be okay in a few. He'll recover in a few. The other thing is breathing. So if you see this patient is turning blue, try as much as possible. That nose, mouth to
Blue where?
Yes.
Blue.
Yes. Yeah. Blue when you're black, like some of us, is hard. Right?
So what's the color preference for black people? Is it purple, perhaps?
Blue black. But you see around the either the tongue, the
fingertips. Yeah.
Yes. Yeah. Not some of us you can't tell whether we are blue or whether black.
Originally.
Yes, originally. Yeah. So you do the mouth to mouth. And also the C is the circulation. Make sure you're doing the chest compressions. So that emergency care. Unfortunately, very few people are actually trained. In the developed countries, you can find a first aid kit somewhere at the bus station.
Yeah.
I think for some.
Yeah.
Here, when was the last time you saw a first aid kit?
So now, answering that question, so what do I do then? Okay, I have not gone through that first aid training.
Yes.
Person has collapsed.
Call for help.
Call
for help.
Okay.
Call for help.
So do you administer the inhaler if they have it? If they have it on their person, and they have this problem, do you then help to administer?
Yes.
Okay.
Yes, you do. Yes, you do.
Okay.
Yeah.
Well, thank you very much, Dr. for joining us today, for speaking to us, and for helping shed light on asthma and uncovering those misconceptions.
Thank you. Thank you for having me as well.
Thank you so much.
Have a good day.
You too.